Be quite as contentious. All-star panel. I've moved into the moderator role, so it should go much more efficiently. Tom, Laurence, Hans, and David, thank you all for joining. Really, just a few slides. Let me recap sunny forecast, and I'm asking you each to comment. I think I have 3 slides. So this is a German-led IIT presented at ESMO. Broad non-clear cell. You see on the table on the right about 60% papillary, 20% chromophobe, and then a handful of each of the other non-clear cells. Frontline therapy, 1-to-1 ipi-nivo versus standard of care, which was by and large TKI monotherapy, I think sunitinib/pazopanib, a handful of IO TKI, and you see the other stratification and data. They picked an interesting endpoint of a landmark OS at 12 months, which we can talk about. This is the primary endpoint. I've sort of taken their slides and rearranged them. So Kaplan-Meier for overall survival on the left. Those 3 dashed lines are 6, 12, and 18-month landmarks. And basically what I've done, I've put the delta in there between standard of care and then ipi-nivo, which is on top. 5-month improvement at 6 months, 8-month improvement at 12 months, and 8%, I should say percent. 5%, 8%, and 8% at those landmarks. And you see the p-values. So they were kind of barely insignificant, then significant, and then barely insignificant again, sort of for what it's worth. Median follow-up's pretty short at 2 years, so there is no overall survival benefit. That's the hazard ratio at 0.83 shown in the upper right there. But again, pretty limited follow-up. And then you see the forest plot on the right, and I have tried to have arrows at the PD-L1, which seems to enrich in non-clear cell as it does in clear cell, and then also this chromophobe signal, which I'm not sure I understand. Let's pause here. Laurence, what did you think of these data when you first saw them?
Okay, the first thing I have to stress is that I'm conflicted. We're the top enroller in this study. I'm glad that this study happened. I think what it's showing us is A, we're able to randomize patients that have non-clear cell, including academic randomization. B, the study confirmed the fact that there is a role for IO in patients with non-clear cell entity, although I don't like to have the mixed bag, and I favor looking at different histology one by one. And 3, the study is positive because the comparator was single-agent TKI, okay? And so I think this is something we have to have in mind because we don't have a head-to-head IO versus IO TKI here.
Okay. Hans, you're an ipi-nivo kind of guy. Were you giving ipi-nivo to non-clear cell before this, and did this change your mind or influence you?
So the data was never really strong for nivo-ipi, and that was the one group where I did not routinely give nivo-ipi, to be honest with you. So I was happy to see that the PD-1 TKI combination made themselves into the NCCN guidelines. The data was very strong, 50% response rate. So that's what I'm mostly stuck with. But I think this certainly surprised me in a positive way. It reinvigorated my thinking about nivo-ipi in non-clear cell renal cell carcinoma. What I do want to see, though, is we need more breakdown, right? So as was indicated, chromophobe probably responds less well to immunotherapy. 20% was at part. So the response rate probably in papillary is going to be even higher than 32%. So I think that's a very positive signal, and certainly above what we know about single-agent PD-1 activity in papillary.
David, same question for you. And would you use PD-1 to select such patients?
You mean PD-L1?
PD-L1,
on the
sorry.
tumor? I think this is a place, non-clear cell, ironically, where PD-L1 seems to help us a little more to enrich for patients more likely to benefit. We saw it in this study. I don't think you have the curves of the PD-L1 positives, but they clearly separate. And the hazard ratio is like 0.5 or something like that, which is, pretty good. Similarly, we saw in Keynote 427, which is the Pembro non-clear cell trial, you were 3 times more likely to have a response if your tumor was PD-L1 positive. So there's more enrichment there. It's not good enough to use as a strict biomarker, but if you're trying to decide, essentially what the question is do you give PD-1 VEGF or PD-1 CTLA-4, and you're concerned about CTLA-4? Well, if you knew the patient was PD-L1 positive, you might be more willing to give
Do you do that in practice? Are you testing for PD-L1?
Well, here's the thing. I have not been testing up until this point. But if you're trying to understand the rationale for exposing a patient to more risk, I'd want that information. That information would help me going forward.
Which test would you use, David? TC or IC staining?
TC. This has been conducted with TC staining.
And that's the one David's going to use? Because that's not what most people are. Globe's not using TC staining because the lung program in most
Correct.
hospitals don't do TC staining. So asking for PDL1 in a hospital, you get lung PDL1.
Right, correct.
And
I mean,
that's not TC staining.
You just have to explain
You can
that
do
to
it
your
in
pathologist.
Dana-Farber and you can do it in Institut Gustave Roussy, but I suspect in Southend busy hospital on Tuesday afternoon when you ask for PDL1 staining, you're not going to be saying, oh, it's for papillary renal cancer, we need TC.
Honestly, this is exactly what we've been routinely doing in the CARE1 study, which actually stratified on the TC. And yes, you have to say to your pathologist, hold on, this is TC, and it's a no-brainer. You need to be quite mindful in the way you ask, but they're doing it without any issue.
Yeah, the other biomarker, if I may just say, should be sarcomatoid, right? There's a weird breakdown that sarcomatoid seems to be its own histology.
Yeah, they didn't really pull it out here, and it was a small number of patients.
It just said sarcomatoid, but that is not its own
4.5%.
histologies,
Agreed.
right? So that's something that needs to be addressed.
Agreed.
Right.
Well, I've got a question in the
Oh,
audience.
Matt.
Yeah, so just on this slide, I think to me what was really reassuring is the 3 and 6 month OS in addition to like the first year landmark, where you're not seeing this dramatic drop off in the Nivo-IPI that raises a huge red flag that there's a subset you're clearly hurting, don't have time to transition over to a TKI, clearly not seen here. And so I think that was one of the reassuring things of this trial as well.
Right, I think
Good
Matt
point.
brings up a good point. Is I think we've been getting, maybe this isn't exactly what he was saying, but I think we're getting better at giving Ipi-Nivo than we did with 214.
Patient selection.
Sunitinib's not very good.
No, I don't. I
Well,
think,
the response rate was actually 20%, which is quite remarkable.
yeah. Yeah.
In the MD Anderson group, it wasn't as high as that in their cohort. David, you go. I've got something to say.
We're getting better at managing the acute toxicity than we were, 5 or 10 years ago. We're also continuing to give maintenance, even if patients don't receive all 4 doses. To me, that's why partly why this data looks good, but it's also why the Cosmic 313 trial is the best Ipi-Nivo trial ever performed.
Okay, let's not go there.
Let's not go there. So go back one for me. My concern around this is that in the papillary group, and I don't love subset analysis, and I don't think over-interpretation of forest plots is a good idea.
But I'm about to do it.
No, but there are exceptions to that. And when you're including groups of patients into a study where perhaps they shouldn't be included, so if you did a pancreas cancer trial and you included a whole lot of testis cancer patients, and you gave them GEM-CIS, you'd have a cure rate of 20%. And then you get this broad label in testis, because 20% pancreas cancer cured by chemotherapy. And so, but the same, including chromophobe patients in papillary renal cancer, they're as different as each other. And so why when our trial design, and don't get me, I love the trial design because it's investigator-initiated, it's a massive undertaking, it's 300 patients, it's randomized, it's immune therapy, it's a brilliant study, it's a great study. And we couldn't have done this in the UK. And I think hats off the Germans, the pharmaceutical industry, I think it's brilliant it was done. But you do have to look at that papillary subset. That's the most of the patients that we see of metastatic papillary renal cancer, and it's not doing anything. And so I have this concern that we need to get away from the term non-clear cell renal cancer as a matter of urgency. And I'm afraid that if we all agree that we do need to get away from this term, then these non-clear cell big trials where the big subset that we're really interested in looks different is a big problem.
So I agree. So we need to have more granularity. There are a lot of questions and data buried in here that I think are going to be very, very useful. I don't know when the trial started, right? It must have taken some time.
Yeah, 5 years ago.
So that was before we knew that chromophobe doesn't really respond to immunotherapy, et cetera, et cetera, et cetera. So kudos to the Germans.
Absolutely. I'm not being critical of that. I'm just saying we should look at the subset. So I'm not being critical of
That's the point.
I am not being critical of the trial. I think it's brilliant, and kudos to them for doing it. But I think we have to interpret the results with the information in front of us and just not say, because it's positive everyone.
For sure. So would you just, moving forward, if you were to repeat this effort or a similar effort, would you just do it in papillary?
Yes.
And so there'll never be a trial in any of these other histologies?
Or I'd do a primary endpoint, so I'd design it.
Powered for papillary.
Papillary, allow the other patients in as well, primary or papillary, then a wider subset. That's how I would probably do it.
Fair enough. This is the PFS, no difference in PFS, 5.5 months, obviously less than in clear cell. PL1 also seems to sort of enrich here. Here you don't see that difference in chromophobe that you did in OS. And again, I think we just get into trouble by interpreting subsets. I think this sort of puts a this is a little bit sobering, right? You're like, oh, ipi-nivo is active, it's active. Then you look at this and you're like, well, it's not that active, right? We don't know if there's a tail. It's only 2 years of follow-up, and obviously it's a lot of censored and limited data after that. Let me ask David, have you experienced or do you think one of the reasons to give ipi-nivo in this subset is the tail of the curve, your durable remission, TFS, whatever you want to call it? Is that motivating in this disease, so to speak, versus clear cell?
Not based on this data set yet, but as you pointed out, we need to see more maturity of this data. But to me, that's the main reason for adding other agents to PD-1 is to enhance the impacts of the drugs after the median. That's the IO story. It's all about tails of the curve, ability to stop the drugs, ability to live in remission, treatment-free survival, that sort of thing. We may see difference in these curves, but even if the difference in the end was 5 or 10%, for certain patients that might be worth it. And that's why you'd have that discussion, and that's why maybe you'd want to use biomarkers to better identify those patients.
David, you did a study called 427. In that trial, single agent, you looked at the papillary cohort in that trial.
Correct.
And in that study, about 150 patients, you showed response rates of 20% and PFS of exactly the same. Single agent pembro, indirect comparisons, quite big numbers, all the shortcomings associated with that. Is IPI doing anything, or is this all driven by single agent Nivo?
Right, so I appreciate you quoting the study. The numbers you reported were not.
Were mildly, they were right. They were broadly right. They're broadly right. They
It
are
hasn't
broadly
stopped
right.
them before.
But no, that's fine. It's
So they
fine.
are right. I think they are right. I think they are right. I've done a little graph.
I'll
I have
gladly
it
show
on-
you the
yeah.
paper after
He's
the
got-
recording.
I have it on the
He's got the
next
graph.
slide.
He's got the graph coming up.
All right, go show to the next slide then. Bring it on.
So we've kind of bounced back and forth between broad non-clear cell and papillary. This is papillary, 60% of sunny forecast, et cetera. And I've really put the major data here, right? So from the PapMet trial, and there was a recent update in JCO from Pedro Barata looking at sunitinib versus Cabo, response rate, primary PD rate, and PFS, which is interestingly not that different.
5.5, 29, 29. It's exactly the same, David. I'm trying to help you with your data. And even then,
I
you
understand, but
torpedo
those
me.
weren't the numbers you quoted. You said 20%. I was going to say it's higher than that.
I think
If
you
you
said
want to
30.
look.
Anyway,
He did.
these are the numbers.
He didn't. I was listening. So the point is, so if your question is where did CTLA-4 add? Well, it may have added at the tail of the curve. We'll see. The response rate is somewhat higher, but to me, it's not the gap between. I shouldn't say this out loud. It's not necessarily the gap between pembro and ipi-nivo. It's the gap between nivo and ipi-nivo, and there you see more of a difference.
You see,
Nivo not producing a result of 29% in non-clear cell patients.
And as I said before, the response rate was 32% for all. Papillary was only 60% of them, so we need the breakdown. Most likely that number is going to be higher, more towards 40%, right?
yeah, the sunny forecasting Cabo Tez were all comers. They didn't break it down. That's what the Astros report. Laurence, did you want to? Were you going to say something? Okay.
So do you understand my point, the point that I made?
But I think the concern raised
No one reacted to it. It was very provocative.
But I think the concern raised is a
Well,
valid one.
Yeah, sorry, I did listen. I can come back to you on it.
Okay, fine.
Hans, you go first.
Thank you.
You go.
The duration of response may be less here, right? So I don't know what it was. But I do think that the duration of response tends to be less in non-clear cell renal cell carcinoma.
Correct.
So I do think you can do the initial response. The question is how can you maintain it, et cetera. That seems to be where the challenge is. And I think that's where maybe additional agents could be quite
Right.
useful.
We're looking forward to our colleagues from Merck updating the data set of 427.
Any of them are in this room. Yes. Laurence, look at these data. Papillary patient comes in, no contraindications, healthy, et cetera, and says, Doc, I'll do whatever you say. Tell me what to get.
So the
The
thing
way it
is,
happens in Tennessee and Kentucky.
so many of the papillary patients can have actually very rapidly aggressive disease, symptomatic, and because I want to make sure that they will be less likely to have upfront PD, I'm going for an IO-TKI. So I'm conflicted, of course, but the clinical sense I had with Len-Pem, and it's pretty much in the same ballpark as the Cabo-Nivo, is that this is where you have every other patient that has significant tumor shrinkage. About 50% of our patients are responding, who have fewer progressive disease. But I agree that this is not a long-lasting response, okay? Those patients ultimately will have disease progression.
Hans, how are you treating frontline papillary?
It's patient selection, careful patient selection. The question to ask is, can this patient progress over the next 2 or 3 months, yes or no? And if they can't, if I'm worried, I'm going to go with a PD-1 TKI.
But everybody else is getting ipi-nivo.
Well, I think that's what I'm probably going to consider now. At least I will, look at the data sets, and then I may incorporate
Was
some
it
of
the
it
German nature of the study that swayed you?
So you have to know that the study did not enroll in Germany. It enrolled in France because in Germany they had IO TKI, so patients would not.
They wouldn't submit themselves to the randomization.
Absolutely.
Oh, that's interesting. Know that.
But the control arm did have VEGF TKI. 17 patients had VEGF TKI IO in it.
So the control arm was standard of care.
Yeah, so
Okay.
it was a mixed control arm. Now, I have no problem with that. Investigator-initiated trial.
David, frontline papillary.
Well, I don't disagree with what my colleague said about looking at the patient and judging their symptoms and rate of progression. The only thing I would add is we're giving VEGF PD-1 as a standard of care in non-clear cell without randomized data yet. So I look forward to seeing those results of those
But
trials.
you just said you'd give salvage ipi without randomized data.
I'm going to give ipi-nivo to
That's
most
a
of my patients
different
unless
standard.
they're rapid.
Okay.
To me, I treat
Putting
clear-
aside the bulky rapid progressors,
Yes,
which is
I would give
your
ipi-nivo.
default is ipi-nivo. Tom?
Correct.
I think this ipi-nivo data supports giving VEGF TKI IO combinations.
Why is that?
Well,
Because of the response rate?
Well, up to now, it'd be very fair. It'd be very fair until now to say single agent VEGF TKI was the standard of care. Monty's PAPMET trial was the randomized study, cabozantinib, PFS out before sunitinib. It was the most robust data we had. Now, David might come back and say actually the pembrolizumab trial, single agent, was more robust because it was larger in number, but it was not randomized. And that creates a debate about randomization versus non-randomization. The guidelines committees didn't love the single-arm trial for various reasons. So we went with the randomized trial, which meant the best data we had was single-agent cabozantinib, although it didn't have a survival advantage. That was the standard of care. And then another series of single-arm trials came out with all the shortcomings of single-arm trials, showing what I think are extraordinary results of 50% response rate and 17 months overall survival. So you look at that and say, I'm really attracted to that data, but there's no proof. There's no proof about the component parts, and there's no proof immune therapy works. What the ipi-nivo Sunny Forecast trial does is it proves to us that immune therapy is doing something. It's at least as good as single-agent VEGF TKI, and so therefore we know VEGF TKI is doing something, we know immune therapy is doing something, and we've got this fabulous phase 2 data with a combination. And that is why Sunny Forecast supports len-pen or cabo-nivo.
That is,
David, what do you think of that rationale?
That's ridiculous. It's ridiculous. You're saying you can't. You're saying you need randomized trials to use cabo. Okay, I'm with you.
Yes.
You can't use pembro because there's no randomized data. And now you're telling me, and all of us in the world practically,
Yes, okay.
that you got to use VEGF PD-1 without randomized data. It's
Let me
incoherent.
let me ask you a different question then, David. Let me ask you a different question. Do we know that VEGF TKI has activity in papillary renal cancer? Yes or no?
Yes.
Do we now know that immune therapy has activity?
I think we knew it before.
No, we didn't know about immune therapy.
We did. McDermott et al.,
On a single-arm
JCO.
trial, I know we didn't buy into it. I think this reinforces the activity. I think for me, it reinforces the activity of immune therapy in papillary renal cancer, and therefore we have these two drugs, both with activity, which is reassuring because when you combine, the results are great, and that gives me the reassurance that I need. Right. And that is not entirely insane.
And sometimes you
it's
arrive
a
at
pretty
an
low
insight,
bar.
not necessarily through a beautiful randomized phase 3 trial, but through a collection of data that eventually comes together, right?
Hans, yes.
So the question now
Hans
is,
is on
do
my
we
side.
need to do randomized trials still with single agent VEGF TKI, right, in papillary? I'm not sure that we need to do that.
Well,
So as a comment, we currently in France have a trial that is axitinib plus pembro versus axitinib, okay? And trust me, it's not enrolling fast.
Yeah,
Okay.
it should not.
This is an academic study. And so this is answering your question. Now people are buying in about the combination and they're not using single agent anymore.
so let's talk about, I think I have one slide on sort of future trials, getting to Hans' point about sunitinib monotherapy as a control. This is just Twitter poll. I think most people are giving IO-TKI, right? Broadly speaking, ipi-nivo, how it was influenced by these data, we didn't ask before and after, and then still a little bit of single agent use. And this is, I think, the last slide. So this is sort of what's coming in papillary. So savolitinib, and Tony's been involved in this and others, the 2 phase 2 trials on the top, where you can sort of see the response in the PD rates. There was what ended up being a smaller randomized trial versus sunitinib, and then phase 3 Semeta, you can see the design there, and then separately Stellar 304, which is Zanza, cousin of Cabo.
For people listening on a podcast, it might be worth saying that do you want me to do?
Semeta is savolitinib durvalumab versus sunitinib versus durva monotherapy, 200 patients, 2-to-1 randomization, and Stellar 304 is also 2-to-1 zanzalitinib, nivo versus sunitinib, about 300 patients. So Hans, you want to comment on the sunitinib control arm in these trials?
I don't know how to advise a patient to consider sunitinib monotherapy.
Meaning you wouldn't put a patient on this trial because of the
I
possibility?
would not be excited about this trial. This is not a question to ask right now. At least the control arm is not the right one. Sunitinib is not an appropriate control arm, at least not for me, not for myself or for my spouse.
So I see a difference between the Sameta and the Stellar, because Sameta is a biomarker-defined population, okay? And we have sunitinib retrospective data activity in the biomarker MET-driven population that actually look pretty decent. It's very not the same situation as Stellar, which is an all-comer, not biomarker selected patient population. So I'm not okay with having sunitinib as the control arm in the Stellar.
Would you rather have Cabo and Semeta?
I would rather have Cabo, but we have data of sunitinib in MET-driven patient population that is doing very well, and I think it was retrospectively assessed also in the PAPMET study, where the MET-driven status there wasn't making a difference.
Yeah, so in the MET-driven population, we're going to have sunitinib as a control arm just to get an idea of where we are, because otherwise people say it's prognostic and not predictive, and we know what sunitinib does. Now, whether or not that would enroll in the US is a different issue, but it will enroll the rest of the world, and I think it will tell us for the next 20 or 30 years, we hope, about what the role of that. No one's going to do that trial again. It's a very, very difficult study to do. So it's important it takes place. Otherwise, the whole thing dies. I think when these trials, I did at ASCO, a presentation at ASCO GU only 9 months ago, where I was very happy standing up with lots of people saying VEGF TKI monotherapy is a standard of care in this disease, and sunitinib from an OS perspective is the same as cabozantinib, is a 50-patient randomized phase 2. I'm relatively happy with that. My position is shifting now because of the ipi-nivo data that I've seen, suggesting that immune therapy does clearly have a role to play.
Nice.
And under that circumstance, that makes my position at Christmas more complicated. It's shifted, and as I said before, I think VEGF TKI IO now is the standard of care, and if you're lucky enough to have access to that, and not everyone in the world does have access to that, then that should be the treatment of choice.
Final word, predict the outcome of these trials. We'll just go down. David, Semeta, Stellar, do you want to take a stab? Did you have a comment, Tina?
I do have
Sure,
a
go ahead.
comment. I think what you're missing there is PAPMET2, because it's all papillary kidney cancer.
Cabo Atezo versus Cabo.
Atezo
Right, there's no
versus
data. That's
Cabo.
why I wasn't on the slide.
Well, but Semeta and Stellar 304 are both
Fair enough.
ongoing trials, so I think we should accrue to the trials.
Agreed.
And that's Cabo-nivo versus Cabo.
Cabo Atezo versus
Cabo-atezo,
Cabo.
and that's a cooperative group study. Fabulous. And great insight and great advertising for that study. You will go for the results of these studies. Let's include that as well, because I suspect that trial will show similar things to Stellar 304.
So let's say, when Semeta, Stellar, and PAPMET2 are done, where do we think the standard of care is? David?
I think Semeta is probably going to be negative. You could argue that one of the arms in PAPMED2 shouldn't continue because we've answered that question about second-line PD-L1. And Stellar could be positive based on what I've seen. At worst, that's a study of sunitinib versus something that's at least as good as Cabo, maybe better.
An IO-TKI, yeah.
So I think Stellar 304 could be positive.
Hans?
Yeah, I don't think there's any surprise here, to be honest with you. I mean, so a PD-1 TKI is always going to be better than single-agent TKI, right? Do we need to answer the question? Do we need to put resources into it? Obviously, Zanza needs to be developed as a new agent. I get it. But it doesn't really help us. The PAPMET2 will not answer anything new. Yes, there will be higher response rates. I don't know what we take from there, right? The question is, can we ask better questions to move forward? The standard now is dual therapy. The question is, how do we go from there? Do we need to repeat single-agent Cabo in our patients? I don't think so.
Yep, Laurence?
So I think Sameta has a little chance to be positive, maybe underpowered. I think Stellar 304, if complete enrollment, will be positive. I think what David was referring for the PAPMED-2 study is that it should discontinue the fact that patients in second line are being enrolled. It should only randomize patients in first line based on what we've learned both from CONTACT and TiNivo-2. So I think maybe this study will be positive.
Broadly agree. Tom, last word.
I very rarely get the last word. I think it's fantastic we're doing big randomized trials in this disease. I think patients, I hope, are not being put in harm's way because of them. From a global perspective, I don't think they are. I think they're getting additional opportunity because sunitinib is the standard of care, and having the opportunity to have these new drugs is a good thing for those countries, not a bad thing. And so I'm really delighted that for the first time, we've got these big randomized studies. We're going to answer really important questions in this cancer that has been left behind for such a long period of time. We only go back 3 or 4 years, and everolimus versus sunitinib, 25 patients in each arm was the standard of care. So this is leaps and bounds. This is huge progress, and I think it's fabulous that we're going to answer these questions, and I think we should enroll aggressively into these studies where we can.
Excellent. All right, thanks everyone.